where's all the money? Well, there's a lot of money with Ohio Medicaid. And we went to them, and the latest agreement we have, which was established last year and is in effect now, is to develop the health system. And actually, Ohio, using Medicaid dollars to pay staff time, IT development time, purchase various pieces of software we needed, was able to deploy HELPS at the end of August, and we have walked away from Stellar, and the program now is operating on HELPS. Now, we have ongoing development and maintenance money committed from Ohio Medicaid to continue to develop HELPS. We're going into new negotiations this fall, and I really look to see development dollars, which are 90% dollars if CMS approves the state plan amendment. So that'll pay 90% of salary, fringe, and indirect for IT folks, surveillance positions, data entry positions, whatever's needed for development. And then we also have an agreement that pays for the ongoing operation of the surveillance system, and that agreement's at 50%. So Ohio Medicaid's paying the 50% of staff time that's dedicated to serving Medicaid-eligible children. And that does include data entry clerks, surveillance coordinators, epidemiologists, and so on. So it's really been a windfall for us. It hasn't been easy. I know over the years I've worked with a lot of my counterparts around the nation and helped them to work through barriers they've encountered with their state Medicaid programs. If I could say one thing, though, it's just persistence, 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 and having an idea and having the willingness to do the work. Even when an amendment's submitted, there's all types of advanced planning it has to go on, and if there's a willingness to participate in that advanced planning and do a lot of that heavy lifting for the state Medicaid program, and more often than not, CMS will come back and look for explanations from that advanced planning document. And our friends at Medicaid are very handy because documents will show up that will say, we have an RAI. Well, that's meaningless to me, but when it's defined, it's a request for additional information. So, they break down to speak for us, they advocate for us, and they've turned into some good partners. But I would say it's all about relationships. As we move forward, we did have a WIC testing program. We don't presently, but we are in the process of proposing a state plan amendment for lead testing of children enrolled in the state WIC program. As we move forward, beginning fiscal year 14 and 15, Medicaid has tentatively agreed to increase the investigation dollars to $615,000 annually. So that'll make about $1 million a year that Medicaid will be investing in the childhood lead program. And we're going to start doing primary prevention work on the elevated blood lead levels below 10. And initially what that is it's not a risk assessment, but Medicaid has tentatively agreed to pay $100 per child to do a home intervention. We're looking at continued Medicaid support for the continued development of the health system and developing our interface with the immunization registry and electronic messaging. And as we move forward, even 5-10 years down the road, we are planning for ongoing operating costs of at least 50%, and we're really excited with that. And, I think it's all about creativity. And I don't want to take up too much time on the call, but certainly most of you guys have my contact information, and don't hesitate to contact me if I can help out.
John, thank you so much, and congratulations on the success you've had there. I'm going to turn now to Tom Carroll, who will tell us a little bit about what's going on in New York State. And Tom, it occurs to me, in addition to talking a little bit about the Medicaid reimbursement, it might be worthwhile just to give a 30-second overview of the primary prevention program, since that's so unique.
Sure. Thanks, everyone. Thanks for having me. I think John said it very well, that there's some some heavy lifting that has to go on, and certainly I'm not an expert on Medicaid or how Medicaid functions or how CMS acronyms or things like that. But I did learn a lot from what New York is going through, and I'll try to describe it. It certainly seems to me so far to be worth the effort. Goes back about to January 2011, but New York State is putting in for they put together a Medicaid redesign team. So before I start here, I'd like to say if you want to see some more details on this, you can go to our website. It's www.health.ny.gov and look for Medicaid redesign team or just the Medicaid. There's a button you can click on it. It'll bring you to a PowerPoint that describes a lot of what I'm about to say. But essentially, the Medicaid redesign team was put together with three goals: to improve health outcomes, to increase access to health care, and reduce costs through effective care management for all. The idea being that by saving health care costs sort of on the output side, that if Medicaid didn't have to pay for bad health outcomes in people, that money that would be saved could be reinvested into the prevention side. So you could, the concept is that you could spend less money on prevention and in the end come out with better health outcomes. So this, the Medicaid redesign team came up with 14 recommendations, and certainly it's more than we want to talk about here today. But I'll focus on the lead piece of it. This is part of what they call, and I don't know exactly the details here. This is my ignorance about Medicaid, about how Medicaid functions. But this is part of an ongoing what they call a 1115 Medicaid waiver. New York State reapplies for these waivers every 5 years, and this is part of the process. This is a new waiver we're putting through to amend the old waiver that had been in process. So essentially, the idea was to look at lead more as a chronic disease model, much like things like home blood pressure, uncontrolled hypertension, asthma in the home. Put lead poisoning into that same category of a chronic disease model that you could save money on the healthcare side and apply that cost savings to the prevention side of things. These waivers are generally for a 5-year time span, and they must be budget neutral. In other words, you have to document that you are indeed saving money for federal Medicaid for this to work out. So essentially, then, if any cost savings you can demonstrate, that New York State's match could be held onto, and then New York State could spend that money. They wouldn't have to match the Medicaid dollars and use that money for the lead program. So essentially, what in our lead poisoning proposal, what we're suggesting that we do is, first of all, to go to managed care plans and ask them, about their customers, about their members, and geographies where they're spending, money spending money to pay for the care of lead poisoned children, and to look at those geographic areas and do something there, and using that information, the kind of money that they put into that, the state would take that dollar amount and identify community-based providers such as county health departments, for instance, to do home investigation and care coordination for Medicaid-eligible children. And then, this would be, a pilot project. It would be phased in over 5 years, and you'd start off with, the highest risk, most expensive areas, and build on that till you came up with, like say the highest risk areas where the most cost, where the most money you spend on Medicaid-eligible children. The services would be a reimbursement program for the local health departments, but they would be looking for reimbursement from us. And since we already have contracts with the local health departments for lead poisoning services and primary prevention projects, it would be a much more simplified process for getting reimbursement. So that essentially would free up some of the lead money that they get to do other things with, like surveillance. It would ease the burden on them if we can get some reimbursement for the individual kids. And after as the waiver came to an end after 5 years, if you could demonstrate that this did indeed save money on the Medicaid for the Medicaid budget lines, it would be included as a regular component of the managed care. Essentially would become a regular process that all counties could take advantage of, and it would fall out of the waiver process and just become business as usual. Rebecca hit this right on the head. This is part of New York State's effort to align healthcare with the Affordable Care Act, which I can't say I'm well versed in everything that's in the Affordable Care Act either, but the whole concept of public health innovation, and putting healthcare, using healthcare dollars more wisely to match up with those features of the Affordable Care Act. The lead poisoning program and our need for continued funding in this program drove us to look at this and include it as like I say, as a chronic care disease model. Say these kids are poisoned, and the care that they need is chronic. It goes on for a long time. So that was our efforts with the Medicaid redesign team. We've yet to hear back on success or failure of this particular piece of it, but we have had, as John mentioned, you get a lot of requests for information from CMS, and we sit down with our state Medicaid folks and the CMS folks and talk about it, and and go over the dollars and cents and justify and talk about where the high risk areas are and the kind of money that the state also puts in for lead poisoning services in these high risk areas. So it's been an interesting process for me and opened up doors. I met a lot of new folks and I learned a lot of new acronyms. But certainly it's worth it if we can if we can ease the blow with the county health departments and get some more federal dollars in here to back up what we're doing with lead. And I'll be glad to take your questions on any of this. If it's something that seems to be some more Medicaid oriented, something I'm not really sure about, I will certainly get back to you to make sure that we got the right person answering the question. Rebecca also mentioned that I would talk to you about our primary prevention program, which is this is a very good program. New York State has some budget. This is state money. State budget lines of about $7 million were given out to 15 local health departments to do housing-based prevention of lead. In other words, we've used our surveillance data. We use our own program called LeadWeb to identify zip codes and census tracts and geographies where most of our lead poisoned kids live. And it's not surprising to me, and probably not to anybody, that most of our lead poisoned kids occur in very small geographic areas. I think 80% of our kids are in about 30 zip codes. It's it's pretty easy to find the right communities to be in. We contract with the counties. We give them, they depending on the estimated workload, we give them various amounts of money, and we give them a fair amount of latitude to design a program that is based on the risk of a kid or anybody developing lead poisoning from the condition of their housing. So they go door to door. They take referrals. They look at lower blood lead levels, and they access the housing. They